Recording in progress.
Hey everyone, how are you tonight? Welcome in to the 3-day EK challenge, day 3. What's up, everybody? Happy Thursday. We have a special treat for you guys. We're going to have Michelle kick it off with her game, and then I'll take over and we'll do the basic twiddly. Even Remy's here. Hi, come on. Hi. Say hi, everybody. Say hi, Remy. So, Michelle, it's all you.
I think Remy wants to get up and do 12 leads tonight, or maybe play in the game.
Maybe.
That would be fabulous if you would play the game with us.
Agreed.
So, okay, guys, I am going to kick off our game. We are going to do a game that I've done in the past, and we're going to see how well y'all can type and how fast you can type. So I'm going to make sure I have chat on board so I can see it. And let me share my screen, and then I can get my chat going so we can make sure. So the idea of this game is to there it is. We are going to race and see who can type in the answers the fastest between Zoom and Facebook. So Zoom is going to be our zebras, and our Facebook participants are going to be baby Yodas. So I am going to, because it does take a little lag on people that are Facebook, and people that are on Zoom have a little bit more advantage to it. So when the question pops up, let me finish saying the question. I'm going to count to 3, and that should give everybody a chance to type and see the answers on Facebook as well as those on Zoom. So we want to make sure that it's that the game is fun for everybody and that we do it appropriately. So if you get the answer right, type it in. I'm going to watch on Facebook. Jennifer, help me a little bit on the comments on Facebook and on Zoom. I'm watching them both on my thing here. And Tori, if you can help me too. So whoever types the answer in first, after I count to 3. So let me count 1, 2, 3 at each of the questions, and then type. And whoever gets it first gets the point, and then the little zebras go around. So we're going to be racing to get to Mars. So let's start and see how this works. We played it before. So sometimes it's a little logistical thing. So let me see how this works. So we should be timing it down.
I see the answers on Facebook. Are you seeing the answers?
Not yet.
We have a 2nd degree type 1 from
No, that can't be
Vivian.
I don't have a question up yet. Hold on.
Oh.
Wait. Wait till I get the questions up. Y'all are just too fast. Okay, here we go. All right, now it's gonna go. Okay, give it a chance. All right, so the first question is, what is the valve called that is between the atrium and the right ventricle? The valve that is called between the atrium and the right ventricle. I want to say the question twice, and then I'm going to count down from 3, 2, 1. So when I say that, now you can go ahead and type in your questions. Oh my gosh, that was like super fast. It was really just about the same, and I'm watching Facebook and Zoom on that one. So I'm actually going to give it on both of those so we can kind of see how this works. All right, so Facebook is going to Zoom, and our Facebook is going to go across, and Zoom is going to go across. All right, so our next question. So that's number 1. So you can kind of see how this is working. All right, so second question. I'm starting off with the easy ones, guys. They're going to get harder. What about the valve between the left atrium and the left ventricle? The valve between the left atrium and the left ventricle. So 3, 2, 1, go ahead and type. All right. Oh, I already have it on Facebook and bicuspid, mitral valve, excuse me, and I've got bicuspid. Hey, Esprit. So bicuspid, mitral, yes, both of those are right. I actually had Facebook popped in the very first one that I saw. So I am going to get that one to Facebook. Okay. So number 3 question. When are the coronary arteries perfused? When are the coronary arteries perfused? 3, 2, 1, and type. I see diastole typed in first, super fast on Zoom. I got diastole, yes. And diastole is correct. And I always am very specific about this. Part of this is because I come from a ventricular assist device and a transplant background. And so I always am asking patients and people, excuse me, nurses and medical professionals to remember when the coronary arteries are perfused, because that time period during diastole is super important. If diastole is shortened because your patients are tachycardic, or if that diastole is shortened because you're in different arrhythmias, AFib, blocks, tachycardias, any of ventricular tachycardias, any kind of tachycardias, diastole is going to be shortened. Shortened diastole means coronary arteries don't get perfused as well. So there you go. Somebody said I'm getting very quiet on my end. Can you hear me okay, Jen? I've got my okay, I've got my my microphone right here by my mouth. So hopefully you could hear me there. Okay. All right. All right, here we go. We're going to go back. And who did I say that was? Jen? Zoom. Zoom had that one. Okay. I remember. All right. All right. So question number 4. What represents diastole on the EKG? What represents diastole on the EKG? 1, 2, 3. So I've got QRS. I've got the QRS. Now we're thinking about diastole. Diastole, that time period when the heart is resting. When that heart is resting and coronary arteries get perfused. And I said, oh, I just saw it. Somebody just typed it in. Okay, KJ got it on Brandy and KJ, Teresa. All right, Michelle, yes. So the answer to that one is actually the T wave, more specifically the end of the T wave. We always think the T wave is when the heart's relaxing and the heart is repolarizing then. The electricity is repolarizing, but the actual act of diastole and when the heart is resting, okay, y'all know I can't do anything without heart on the steak. When the heart is resting, when it's in systole, that's my QRS, and it starts to relax. And when I actually get to diastole, it's the end of the T wave. From the end of the T wave back to that next QRS is actual diastole. So now you can see if your patient is tachycardic, then you're going to be having that shortened time period between the end of the T wave. Yay, heart on steak. Okay, so that was definitely Zoom because I saw people typing that right away. Okay, try logging in. Okay, all right. So, all right, and that was Zoom. Where's my little Zoom? I've got my chat in my windows. I got to find Zoom. Okay, here we go. I had to find it on my screen. Okay, so we're going to go back. And question number 5. The sinus node is represented. Sinus node is also called this. So 2 questions. You got to type in 2 things. The sinus node is called something, and it's represented on the EKG by what? 1, 2, 3. Okay, so 2 questions on that. And I've got the pacemaker, and I've got sinus node and P wave. Sinus node, pacemaker, and P wave. Yes. So Zoom did get that first. And let me go back. There we go. All right. So Zoom did get that one first. Okay, Facebook. Make sure on Zoom that you're letting me count to 3 before you type. Okay, number 6. The AV node. All right, this one we haven't talked about yet. These are some of the things that we talk about when we're in teaching in our class and some of the specific things we look at with coronary arteries. The AV node is perfused 90% of the time by the what? 1, 2, 3. Now you can type. The AV node is perfused 90% of the time by the what? What perfuses the AV node? What perfuses the AV node? Oh, here we go. Marcel is typing it. Nuria is typing it. The RCA. Yes, the right coronary artery. And Jennifer's going to be talking about those coronary arteries tonight. And we are going to be talking about them next week when we start talking about the heart on a stick and all the coronary arteries. So the right coronary artery gives us our perfusion to that node. Okay, and that was, where are you, Zoom? There you go. Okay. Okay, number 7. The RCA also perfuses what part of the heart? 1, 2, 3. What else does that RCA perfuse besides just that node? What else does it perfuse? Oh, we have Esprit, the inferior wall. Matt, all right. You go, Facebook. You go, Facebook. We've also got Marcella, the inferior wall. Catherine, the back of the heart, the posterior. Yes, all of those things. Okay, so where is Facebook? Oh, there it is. Okay. Sorry, the screen gets taken up a lot with all the chat, and I'm trying to make sure I'm seeing it all. Okay, here we go. The left main, that left main coronary artery. I'm going to bring up heart on the stick so you can see it. That left main heart bifurcates into what? 1, 2, 3. The left main bifurcates into what? What does it bifurcate into? Okay, we've got Zoom saying the circumflex and the LAD, and Matt typed it in just as fast on Facebook as well as Vivian. Okay, we've got the left circ. So that's the one that's going around the side of the heart, the one that's going on the side of the heart, and that LAD that's going down the front of the heart. All right. So both Facebook and Zoom got that one. Okay. Where are we? We are on number 9. We may end up without going through all the questions, but wait, the back of the heart. I'm always particular about the back of the heart. I have I have like favorite parts of my heart. The back of the heart. Who perfuses the back of the heart? Who perfuses the back of the heart? 1, 2, 3. Okay, who perfuses the back of the heart? You can type that in, the perfusion of the back of the heart. What coronary artery can perfuse the back of the heart? All right, Nuria. And yes, Nuria and Brandy and Matt. Oh, both at the same time. I'm like watching both of y'all to make sure that you're getting it. Yes. The why are we not going? There we go. Okay, so it's either the right side of the heart, the right coronary artery, which is one of the oh, what's my word I'm thinking of, Jen? When you're right dominant or left
dominant. Mm-hmm.
The right coronary is your most dominant, but we also can't forget about that left circ. Okay, so both Zoom on Facebook. Matt, you are a fast typer. Okay, almost done, guys. Number 10. The pulmonary veins, I want you to think about coronary anatomy. The pulmonary veins, are they either oxygenated blood or deoxygenated blood? 1, 2, 3. Oxygenated blood or deoxygenated blood? Oh my gosh. Both Esprit, Dana, and KJ on Zoom and Nuria. Man, y'all are fast typers. I don't know how y'all type that fast. I can't even spell that fast. Yes, oxygenated. I'd be like, oh, and that'd be all I'd get on there. So y'all are pretty good. That's why I do the games and I don't have to type. I always struggle with the typing on the computer. Okay. Actually, sorry, Facebook was one thing behind, and part of it's the lag. I know it's part of it is the lag.
Zebra Zoom.
Yeah, Zoom won on that one. Zoom won. All right, we had one other question. Let me ask one other question, even though we got all of it, because this is one of my favorite things. is what wall of the heart does that left circumflex actually perfuse? Type in the answer to that. Well, that'll be our bonus question. What wall of the heart does that left circumflex perfuse? Michelle's saying fast fingers, not me. Yeah, Team Zoom rocks. So that left circumflex, yes, Jess, it's that lateral wall. Yes, Matt, the lateral wall. And we say lateral wall. I don't know why everybody says lateral wall, but there's two walls of the heart. But when we say the word lateral, we tend to mean left lateral. So specifically, it's that left lateral, and even more specifically, the high lateral wall, the high lateral wall. And we go over all kinds of stuff in the class itself and give you even more ways to remember those things. As you can see, we're pretty visual. All right. That's it, Jen. Was I pretty quick tonight? Yep.
You were, and it was perfect, actually.
So those are the things that we do in the EKG classes.
Except we do a lot more with EKGs, but I love the anatomy because Michelle's kind of our anatomy queen. Yeah. So thank you, Michelle. You are amazing. And thank you guys all for playing. I hope that was fun. Type in the chat. Was that fun? Because we are all about fun. So type in the chat. What do you think? Was that game fun? Do you guys want to do more of the games? Yes, always fun. Good. Okay, good. All right. So this is Michelle. I get to see Michelle again live in person next month. And you guys can come too, by the way. We're going to be in San Antonio on October 5th, live in person. And we're going to be doing a workshop, an EKG workshop. So if you guys want more info, just message me. I'll get you the link. And I know you guys, if you've been following me for a while, you know that I do live lectures. I'm doing a lot this year, but then next year I'm retiring from live lecturing. So if you do want to come out this year, we'd love to see you. Obviously, San Antonio is the place to be because Michelle will be there. And next week, I'm going to see you too, Michelle, right in Pensacola next week too. So
yes, next week in Pensacola, and then in 2 weeks in San Antonio. And y'all come because we're going to do a barbecue also.
Yeah, and you can come have barbecue with Michelle and I and all the people. So it'll be fun. All right, so let's do tonight, which is day 3, which is basic 12 lead. And I do want to announce the winner of who won the scholarship for the 30-day EKG challenge. Now, remember, this was going to be given to the person that was the most active, was the most helpful to other people. And it's no surprise that KJ actually won the scholarship. I don't know if you've been seeing KJ's comments, but they've been on fire, rooting people on, helping people when they got lost. And that's exactly what I was looking for. So thank you, KJ, for your just untiring dedication to helping your fellow students. We really do appreciate you. I can't stress that enough. And you always make it, even if you're working, and you just tirelessly give back, which is literally the whole mission of this group. So thank you, KJ. So just wanted to announce that. And let's get into some learning. We did anatomy with Michelle. So that was super fun. But we're going to now switch gears to a little bit more on the EKG and the 10-step system and give you a little intro to that. Now, there is a page in your workbook that goes along with tonight, just like every night. So if you want to download that, I think Tori's on this, she can get you the workbook link. It just downloads into Messenger, and you can print it out or work on your iPad if you have a pencil, whatever you want to do. But this is what we were talking about, just to kind of recap day 1, where we said, hey, these software interpretations, our coach, David White, he likes to say that software interpretation is written by the plaintiff attorney. So it's not written to help us as providers. It's written to trip us up. And that's why it's only right 6 to 42% of the time. And the study is listed there if you want to look it up. But basically, it doesn't get very many things right very often. So if we use that, then we can get in trouble. We can miss STEMIs, we can call STEMIs inappropriately. And of course, either way, you just can't be wrong. You're not allowed to have a 6 to 42% miss rate. So it will oftentimes get the intervals right, which is the numbers on the top of the EKG, and it will often get normal sinus right. But the rest of it is kind of a crapshoot, just to be really honest with you. So here's Remy. You met him if you were on earlier with us. He was saying hi. So Remy is actually my EKG reading German Shepherd. He was literally named to rhyme with STEMI with Remy. He actually has a bandana that says that. Michelle made it for him. But he has a couple pieces of advice for us, and he's very smart. So he says, as a reminder, T waves are all upright, except for the two leads. We talked about this night one. We're just recapping, right? Inverted, they should be inverted in AVR and V1. Now I want to stop for a second because I got to work and I had two students following me. I didn't know I was going to have either of these people. And so I decided to make it fun and for them. And so did my doc I was working with. So I gave them an EKG. I just wanted to see where they were. I said, okay, tell me about this EKG. And I was watching where their eyes went. The first one, she was like, oh, the T waves are elevated. And I was like, okay, we're going to stop right there. I know what you're saying, but you're not saying it right. I said, listen, half the battle with this is when you talk to anybody, you got to speak the right lingo, because otherwise you look like you don't know what you're talking about. Right. So I told her, I said, hey, so T waves they're peaked, right? And she said, well, what about, aren't they elevated? And I was like, no, ST segments are elevated or depressed, but T waves don't get depressed because they're the babies of the family. They don't get depressed. And so she was like, oh, okay. So there's certain terminology you can only use in certain parts of the EKG. And then I think she said something about like a camel hump of a P wave. And I was like, okay, that works. I know what you're talking about. We're talking about a notched P wave, but there's so much terminology. I stepped back today and I was like, wow, I didn't realize when you're learning this, because it's been so long, I didn't realize how much just the language is rough. So I'm really glad that we did a lot of that on night one. We didn't obviously cover everything. We do more in the 30-day EKG challenge, but I realized that if you're new, it's like learning a foreign language, but learn that foreign language, because when you talk to other professionals, that's how they look at you. That's how they know if you know what you're talking about. So intervals are the numbers, okay? And those are the numbers at the top. They need to have a normal reference range. We actually, in the 30-day EKG challenge, we take a normal EKG and we actually make it into color coding. We give you crayons to do it. We have you write down the normal intervals next to the numbers, and we have you literally create a cheat sheet so that you can take a photo of it and have it as reference when you go to clinic. Because when you're in the thick of it, this is another thing I realized. My students today went into a little bit of vapor lock because I realized they hadn't been with me before. They didn't know what to expect. Here I am putting them on the spot. It was probably intimidating, even though I didn't need it to be, but their brains went into vapor lock. Mine did too when I was growing up in the EKG world, right? So when you go into vapor lock, the trick is to have something to get you out of it. It's like breadcrumbs, like a trail of follow to get you out of it. So you have tools. You can look at your cheat sheet and you go, oh yeah, that's right. I remember we covered this. I just have to do my 10-step and I just have to remember these things. And I have my crutch, because when you're learning this, you need a crutch. So the one says to me today, the newer one, she says, and she's so sweet. I really like her. She's going to do great. But she says to me, when did you feel comfortable with EKGs? That's a very valid question, because you got to think about it, right? Paramedic for 13 years and then now PA for 16. You would think that I would be like, yeah, I'm so solid, right? Okay. And I am, but I like this because there's still something to learn. So today in our 30-day EKG challenge, Coach David did a session at 2:00 Pacific. So I was at work and I actually had my students watch it because I was like, okay, this is great. He's going to cover the basics and it would be good for them. So during it, he actually reminded me of something and I forgot. And I thought, oh my gosh. At first I was like, what a dummy, right? Like I'm such a dummy. Then I was like, no, that's why this is so great, because if you don't use it, you lose it. And also because you can still learn new things, and there's still new things coming out. In fact, November 2022, they came out with a whole new criteria for STEMI equivalence, which is like mind-blowing because there's all these new stuff to learn. And I was like so excited. So you never get bored, but it's also scary because you never really feel like you know everything, and that's normal. Even David sometimes asks questions. The person I hold to the highest esteem honestly in the whole EKG world. I'll just say it. He's number one. Okay. But my moral of my story, and I'm sorry to get off on a tangent, but I just feel so passionate about this, is that if we're not all the time knowing every answer, how can you? So don't hold yourself to that standard. Here's the trick. Here's the secret. You have to know the things that will kill someone, and you have to know them well, so well that you don't rely on crutches. Okay. So like when here's the strategy. Okay. You learn the basics, you get that down, but the next thing you do, you don't worry about axis and vectors. No, doesn't matter. Okay. Don't fill your head with that. The next thing you do is you go straight to the high risk things and you learn those, because the ones the machine will not pick up. And that's the way you stay safe as a provider. Okay. That's like my recipe for you to get good at this, because honestly, in EKGs, it's so high risk. There's so much to know that you have to be scrappy. You also have to choose what you're going to spend your time on, because it's limited. You got kids probably, right? You got pets, you got to exercise, you got to cook, you got a spouse you got to, hang out with, and all of the things, right? You got to do laundry. So if you have a little bit of time, you got to choose how to spend it. So this is how I would spend it. Learn your normals, learn your high risk, then add in the rest of the stuff. And that's literally how we structure our class in the 30 DK. Because I was like, listen, I gotta go back to my roots, how I learned it. I got to see what happened, what went wrong, why I almost wanted to quit, why I felt like a complete moron. It wasn't me. And it's not you either. It's the way we teach it. Okay. So just know that there is a pathway out of that feeling. There's a pathway to feeling more comfortable. You're probably never going to feel completely 100% solid. And that's kind of good, because what it forces you to do is to keep studying, to keep questioning, to keep asking. And I will tell you that even now, right? And not just with EKGs, but even now, I know where my limits are. I know when I don't know, so that I go ask. And there's never anything wrong with that. Have somebody you can ask, because we're never going to know it all. Okay, I got to get off my tangent. Okay, so and then normal voltage, right? We talked about that, high or low. Okay, high or low. Michelle, thank you for emphasizing. And yes, Jess, occlusive MI. Yes, that's what I talk about. Those are the new semi-equivalents, and no depressed babies. Exactly. So, well, in the family, we talked about that, right? The mom, dad, baby, that's super important as well. So the normal EKG should look like this. It should have wonderful, beautiful lines. There should be no artifact. Okay. And then also there should be no extra beats. Also, the voltage of the R waves, which is right here, shouldn't be too tall, shouldn't be too small. Okay. So I asked, I'm flashing back to today, because my student, after they watched David, so he's really smart, and even teaching the basics, I said, what did you guys think? I kept it really open. And at first they were like, oh my God, wow, that was really hard. The beginning wasn't, but he went into something later called Whelan's warning, which is a biphasic T wave in V2 and V3. And they said, but what was helpful was he drew it. He pointed it out on the EKG, then he drew it, then he pointed it out again, and then he pointed it out again. And that made me realize that, okay, that's also so important, the repetition, right? You need to see things more than once, especially those high risk things, to the point where they get burned in your mind as little like snapshots. Oh, that's what this looks like. Okay. So we will be instituting more repetition. Now, the other thing that I really want to call your attention to is this blue line I made here. Okay. So this is probably not something you're doing, but you should be doing. Each and every time you look at an EKG, you should be looking at this line. Now, I know if you attended Gary's session last night, we talked about, he showed examples of ST elevation and depression, but in a nutshell, you're making this straight line to look for elevation and depression of the ST segment. And what you do, I'm going to just draw this for you, is you go to the end of the T wave to the beginning of the P. Right here. This is called the TP segment. Okay. And you're using this to make your straight line so that you can see if there's elevation or depression. And why would you spend time doing this? Because very often the ST elevation can be very minimal. And if it is, you may miss it. So you always want to make that look for your elevation or depression. Okay. Yeah, Michelle is good about repeating key points, and there is no judgment in this group, which is why we love it. And this is pointing to AVR and V1, which has the T waves inverted, and then the T waves are upright and all the rest. Okay. So everything's looking good. And you have this beautiful, discrete, wonderful P next to the QRS, next to the T. They should all be holding hands together like a family. And that's what is normal. So now that you have an idea what normal is, also your R waves, these are your R's, should be pointing up in lead 1, 2, and 3. Let's visit this EKG and let's talk about it. So at this time, these are called the intervals. And so you can see here, all these numbers are the intervals. And these all have normal reference ranges. Here's the problem. They don't list these normal reference ranges for you. And so if that's the case, you don't know, right? And I will tell you that there's clues that live in here. So these are numbers you really want to know. You probably know this one. You know the QTC, right? And you know that it's this number here. That's probably a really bad circle, but it's this number and it shouldn't be more than 460. I think we talked about that in the first day, but this can lead to something bad, right? It can lead to torsades de points, and you don't want to give medications that prolong the QT. So that's a number you probably know. And also I'm going to just show you the EKG. This was done at a hospital near us, and it says normal ECG. But you know what? It's not. So I just wanted to share this with you. This T wave is not supposed to be inverted. It is inverted. And also this is short, this PR interval, okay? So technically there's two things on this at least that are not normal, and the machine says it's normal. Did we actually dissect this EKG? This is the one we make into our normal cheat sheet in 30-day, but just showing you, this is an example that no, don't trust machine. It's going to lead you astray, and you don't want to do that. So with that being said, it's not normal. And I also just wanted to really quickly label these leads for you. So a lot of you probably already know this is probably review, but these are the leads that are, as Michelle was talking about, the lateral leads, right? And these are the leads that look at the septum. These are leads that look at the anterior wall, the V3 and V4, okay? And then the lateral wall is V5 and V6. And what we do is we actually group these in a color so that you have a map. What we actually do is we have Michelle take heart on a stick, and she shows you what this looks like in 3D. We actually take this over a heart and we show you how does this correspond to the anatomy on a 3D heart. And I show you a trick so you never forget this. Because honestly, this is the way we learn it. We learn it on this piece of paper. We are told, we say, okay, contiguous leads, we're taught that term. And you know what? That only really applies for Q waves and for STEMI. So contiguous leads, you need to have ST elevation. Contiguous leads, you need to have reciprocal changes, which is ST depression. Now, don't worry, we cover all this in detail on the 30-day, but this is just the terminology you should know. And this is for STEMI. And we also learn that this way. This is my problem. This is how we're taught this, right? We're taught, hey, location of the infarct, what artery supplies it? What are, right? Where are you going to look for the changes? But they give it to you like this. I never could do this. I never could memorize this. I feel like we memorize so many things. This should not be one of them. But we also can't just rely on looking at this either. You have to conceptually understand this. So what we do is we actually give you a map that is a quick picture that shows you the reciprocal changes versus the where you would look for reciprocal changes and what the contiguous leads are. But what we do with you is we have you color them so that you start to understand who's connected, who's contiguous, and then we have a map for you. So know that you could use this, but if you're someone that's like super visual, that needs all the good visual clues, that's how my brain works. That's how I teach you this. And it's funny because this is what I teach in the workshop that we do around the country. And I actually get to see, which is so cool, I just see people coming in and they're always scared. I always go around the room. Hey, how are you feeling? Oh, I'm really nervous. And okay, that's fine. We're going to take good care of you. And by the end, they're shouting out, like literally in 2.5 hours, they're shouting out the answers. These are all like really afraid people, just like maybe you are. And so the system we use is pretty magical. I'm pretty in love with it. Because I see it work in such a short amount of time, because nobody has time to spend hours and hours and hours. So anyway, okay, let's get into our workbook. Let's get down to it. Oh, a balloon. That's a good idea too, Jess. You had a good instructor. Wish we would have done that. Okay, so let's fill this out. So our workbook page, contiguous leads. They are leads that are fed by the what? Let's put in the chat. The what artery, anatomically speaking? Visual Insight says, loves the visuals. I love that. Okay, so these are, yes, the same artery. Okay, so this is the same. Now, ST segment, we're talking about reciprocal changes. I'm going to just tell you, this is, people are like, are you throwing, at the workshop the other day, they were like, are you throwing gang signs? It's like, no, but I realized I was doing a lot of things with my hands. So here's how I tell people, okay, STEMI, ST elevation, you got to have 2 up, 2 down, right? So you can put that in there in your reciprocal changes, 2 up, 2 down. That means you need to have 2 leads of elevation, 2 leads of depression. Okay. And you can see that happening over here in this EKG. You can see when you draw it out that you've got, and this is a small one, it's on your paper, so you can do it, but you can draw out the elevation in lead 1 and AVL and the reciprocal changes down here, and 3 in AVF. So you do have your 2 and 2. And I put this in there literally so you could practice it. And then you've got, you're going to write in the leads. Okay. So we're going to go back and we're going to refresh our memory on what are the leads that are the inferior. What are the inferior leads? Okay. So you've got 2, 3, and AVF. Nice job, Michelle McKeegan. Nice job, McMicken. I actually, I've loved chatting with you lately, Michelle, by the way. And KJ, good job. And what artery feeds the inferior leads? What artery is feeding the inferior? And Michelle, I think, just kind of covered it. Yes, Michelle, you are spot on. It is the RCA. Good job. I want to see some activity on FB. Give me some FB love. All right. Now, anterior leads, they are V1, V2, V3, and V4. And they are fed by which artery? Which artery feeds V1 through 4? And Michelle will teach this. I love the way she does it. She says they're like sister leads. It's so perfect. Jess, exactly. Michelle, yes. Good teamwork on here. And Logan, Matt, what's up? You guys are all right. It is the right coronary artery for the inferior and the LAD for the anterior. Strong work. Good job, you guys. Okay. Now, thanks for typing it in. KJ, this is what I'm talking about. Do you see why KJ wins the scholarship? Anyway, lateral leads. Okay, we've got one more set of leads. They're all sisters and they're all looking at the same part of the heart. So you've got lead 1, AVL, V5, and V6. And Michelle McMicken put them in. Thank you. Yay, Michelle. And then also they are fed by the, which artery? Which artery? Nice, Logan. And so there's one, yes, Nicole, yes, Michelle, circumflex, good. Okay, so you guys nailed this. Just a little recap of the normal EKG. So here they are. Hopefully you can read my writing, which is just what we went over, and covering the leads and what artery feeds them. And so now we'll cover, and this is the next page in your 10-step system. This is a approach you can use if you want to in reading 12 leads so that you have an organized system. So I think I told you guys the story on the first day, but if I didn't, I'm going to recap it, because basically, and I saw this happen today with my sweet students, and I've done it when I was new, we get what I call swirly eyes. So if you remember Jungle Book, the snake, I think his name is Ka. I meant to put his picture in here for people who didn't know, but when he sees something he really likes, like he sees the kid, he like gets swirly eyed, like, ooh, okay. So we get swirly eyed when we see something that is so wicked cool for us. We're like, oh, like a cool T-wave. And when you do that, when you go straight into the EKG and swirly eye, that's a verb, I just made into a verb, then you can miss the STEMI. And I have an EKG in the workbook that I send you. And I actually pimp people on it. And I'm like, let's show me what you see. And I tell me what you see. And I see if they pick up where they go, where their eyes go. Cause I'm just curious, where are your eyes going to go? And I like people to see where their eyes are going to go. So then I can say, this is why we use the 10 step, because you missed the inferior step. Like, this is why, right? So let's do this really quick. This is actually step by step. Big sick versus little sick for people who are not medics. I don't think a lot of you were taught this. And I didn't realize that for a long time, that it's a medic thing. But here's the thing, it's perfect for everybody. Because if you have a patient, you walk in, they're pale, cool, and diaphoretic, or they're in asystole, or VTAC, VFib, all the things, then it's a big sick patient. Okay, yes, medics do it. And if it's big sick, you're not doing anything else. You're getting them where they need to go. If they're in your clinic, you're like, start CPR, right? If they're in the hospital, you're calling code. Wherever you work, you're doing your thing. Now, if they don't have big sick and you can look at the EKG a little bit more, you're going to go down and look at it and see if they're what their stuff is, right? Their rate, their rhythm. You're going to look at their intervals. You're going to look at ST segments, and you're going to make sure that everything is normal so far. You're really scrutinizing those segments. And KJ always says this. What's the saying about the ST segments? Let's see if I'm right, if KJ is going to put it in. What's the saying, KJ, for the ST segments? What do we always do? What do I say like over and over till you guys get tired of it? I say, draw the lines. Exactly. Okay. Make those lines that we showed you, because they are so valuable, and they do show you if you have ST elevation or depression. Okay. And sometimes it can be so subtle, even like a 0.5 millimeter or a millimeter, and the millimeter is all it takes in some leads. And we cover more details on that. But knowing that just how to find it is half the battle. That's the first part, how to find it. So you measure your ST segments. You look for Q waves, right? Are they present? If so, where are they? If so, are they part of a pattern? If so, are they new? If so, are they old? All the things. Q waves, I actually do like a whole 6-slide lecture in the workshop on this, because the Q waves, as it turns out, there's a lot of things to know. And I'm going to teach you all those things. But knowing that they're at least a third the height of the R wave, that's sometimes very important, right? Because if they are, then they're bad. We talked about that on night 1. And then axis, I'm going to tell you something, okay, that's going to make you feel better. Axis is not critical unless you have a pulmonary embolus or you have a wide complex tachycardia and you need to figure out what the rhythm is. Otherwise, axis isn't very important. Now, it's funny because I didn't always feel this way, but as I look back, it's really not. And a lot of people fret over axis. And I know I fretted a lot, but I'm going to tell you that it's not something to like hone in on. Instead, focus your time on those high risk things, OMI, like Jess said, or the subtle things the machine's not going to pick up that are deadly. Okay. So axis, though, to make you feel better, in the box that I mail you when you join up for the 30-day, I actually put an axis chart in there. So you never have to learn axis. You literally can just look at my little system and you're like, oh yeah, good. I don't even need to worry about it. Even though it's not, I still have this chart and I'm good. Because literally, if you can't figure out the vectors and all the other things, you need a way around it. I'm going to give you the chart. Okay. So then hypertrophy, you need to look at, is there a lot of voltage? Is the tissue thick? If it is, it's not a today thing. It's a long-term thing, but we need to know it, right? Do they have a lot of voltage? Do they have a lot of thickening? If they do, we better get on top of their blood pressure or they're going to have heart failure. Or it could be a sign of hypertrophic obstructive cardiomyopathy, which is lethal. And we can't miss, especially when we do sports physicals, which I talk about in our workshop. So don't worry, I'll cover that. And then T-wave rules, we need to know that. We covered a little bit of it. We said, hey, inverted in AVR and V1, upright everywhere else. But there's other rules. They can't be too pointy. They can't be biphasic. They can't be upside down. They can't be symmetric. Like all these rules. And what do they mean? There's so many things. So like Q waves and T waves, believe it or not, there's actually like a whole nother world out there you've never heard of. And I feel like, honestly, we should be sitting on top of the rooftops and shouting this because it saves lives. Peaked is not good. Exactly. And then there's something called the chief complaint-based approach, which is your last step, where you go back in and you look at the EKG. So for example, let's take syncope. Okay. So when you are seeing, excuse me, a syncopal patient, you always want to document if they have something or they don't have something. So for example, let's just use prolonged QT as an example. So when you're going to do your whole check, okay, but then you're going to go back in and you're going to look specifically at the EKG with the syncope eyes. Do they have these 5 things, right? And one of them is prolonged QT. If they have it or they don't have it, you document it because it means you looked for it. It means you thought about it. Torsades is what happens that leads to the syncope with prolonged QT. And you're also, I want you guys to be obsessed with the QT anyway, because it'll keep you safe and you won't prescribe new medications that prolong your QT, and then you won't get in trouble, right? You'll know the QT meds and then you'll avoid them because you'll know that's bad news. We'll talk about, what medications are QT prolonging as well, because that's important to know. There's like a list of 460, but I'm going to tell you the common ones because you don't need to know all of them. You're not going to use like half of them. So I put this in here so if you wanted to do what we did on night 1, you could label the conduction system. You could match it up to the 12 lead here if you wanted to. And so this is Michelle in San Antonio. This is our wonderful Esprit. I don't know if she's on here, but we were just messing around at a live conference. I feel like all meds are QT prolonging. I know, Nicole, it does feel like that. They're not. And knowing the ones that are super critical. 2 that are big, Zithromax and Zofran, we use them all the time. So we got to be careful with the 2 Zs, or what I call them. So the 10-step system we talked about, here it is. You can practice this. There's 2 flavors, and Michelle actually gives us in the 30 days, she gives us a clock method. So we basically give this to you 1,000 different ways, and we run through a practice program with this, so you get practice doing it. If you don't have a system already, if you have a system, don't use mine. Use yours if it works. This is just in case you need it. Okay, so we're going to do a couple cases. These are kind of fun. This is nobody's real face, okay? But this is somebody who said, I have shoulder pain when I work out at the YMCA. So this is kind of just a sample of like scenarios that we do in the 30-day. So this was a real case too. He has a history of hyperlipidemia, hypertension. He's on aspirin. He's got the trifecta, as I like to call him, and he's got shoulder pain. So, all right, he says it's probably my arthritis. Well, it's not arthritis until it's not something else. Okay, so here's his EKG, and this is where I'm just going to share with you the value of doing your lines. So what you would do is you would go and on step 5, you would draw your lines out. And when you do this, when you first looked at this EKG, I bet this didn't pop out to you like a snake waiting to bite you. But when you make the lines, it becomes so much more clear that there is significant ST depression. Okay, so when you're doing that, you'd actually do all the leads, but I know the leads already, so I'm just trying to expedite this for you guys. But basically, there's a multitude of leads with depression, and there is one lead with elevation. Does anybody know what we have to worry about with this EKG? Does anybody know what we need to worry about, and is this something bad? I mean, it just says non-specific and non-specific. So what do you guys think? Is this anything to worry about? AVR is our friend. Okay, so inferior MI. So if you have ST depression, let's go look to see if we have enough elevation. So when you draw your lines, there really is an elevation in F. And in 2, there's actually depression. So it would be 2, 3, and F, and it doesn't really have enough elevation, but it does have depression. Okay, it does have a lot of depression, and AVR is elevated. So this, I'll just tell you guys, this patient had a critically occluded LAD, critically occluded. How would you know this? Because this is one of the patterns that is the big bad wolves. So I know this is a little more advanced, but I wanted to show you a real EKG and why this is so dangerous if you don't learn it. Would you have picked this up? Would you have said, refer to cardiology for non-specific T-wave changes or ST T-wave changes? Because that's what the machine said. But this is someone that can't wait. This is someone that needs to go to the ER today, that needs to have an angiogram today. It's not a STEMI, but they need to have an angiogram today. Okay, so drawing your lines, learning these patterns is so worth your time. What if this guy didn't? We didn't pick this up. Okay, what if we didn't pick this up? It could have been bad. He actually had a stress test that was awful, and he went and got a stent in his LAD. There's also this sports physical. So this is not a real patient's face, but so critical. This guy, he says, oh, I just want to play. Can you sign this form? Happens all the time if you're in primary care. This is one of the reasons I left primary care, because I was like, no, this is too high risk. And I didn't know what I needed to know. And I knew that to keep kids safe, right? So this is one of the things that you look for. So you ask about syncope, you ask about chest tightness with running, you ask about dizziness with exertion. And when they tell you that they're fine, really, they're probably not fine. Okay. When they turn into a car salesman, they're probably not fine. So they're lightheaded with running. This is all bad. So of course, they also have a murmur. Hint, hint, hint. Does anybody have any clues of what this is? The murmur gets softer with squatting. Softer with squatting. This is one of the big bad wolves. Yes, exactly. This is definitely. And now you have the EKG to help you support it. This is someone with hypertrophic obstructive cardiomyopathy. This is one of the things, if you do sports physicals, you should be documenting that they don't have. Good job, Matt, and good job, KJ. So you can see they have skinny, narrow dagger cues in 1 AVL, V5, and V6, skinny, narrow dagger cues. If you didn't know on your 10-step to look for the cues, nice job, Logan, you might miss this. So the murmur, the symptoms, and the EKG are going to have you get an echo. And you're going to look for thickening of the ventricle, which is a real diagnosis, but he's going to be benched in the meantime, right? And honestly, if you're seeing this kid, you might even be sending him to the emergency department. Here's another great case, not a real patient's face, of course. Patient has palpitations. I'll tell you, when I work in the ER, if I have a patient I'm seeing that already has an IV, I know the nurse was worried, right? So probably going to be pretty unstable. So I run through my differentials with Remington and I say, okay, Remy, what are the differentials for a young person with palpitations that the nurse has already put an IV in? I'm thinking they're probably pretty fast, right? Probably anticipating needing some adenosine, SVT. They could be an AFib with RVR, all the things, but I know I'm going to get an EKG. Thank you, Remington, for being the EKG reading German Shepherd. And here is his actual EKG, you can see. And I want to hear what you guys think about this. What do you guys think about this EKG? Okay, this is actually his real EKG. This was that young 21-year-old, his EKG. So just to orient you, here's your 12 leads right here. Here is your rhythm strip pulled out for you. And my question for you is it regular or is it irregular? Okay, is it regular or irregular? This is none other than the beautiful, as Maricela and Jess also pointed out, that it is irregular. And Teresa and Maricela, yes. So Teresa, whenever Teresa's on, Teresa's a monitor tech. Pretty much, haven't seen her answer like wrong ever. So if you want to cheat off somebody, cheat off of Teresa. But yes, this is none other than the beautiful AFib with our VR. Now, here's the thing. This, if you look at it just really quick, you could think it's SVT. But when you really go down and you map out the R to R, it's irregular, making this not SVT. But you're like, well, what's a 21-year-old male? It's got to be SVT. That's part of your differentials. But it's irregular, so that completely rules it out. It's not SVT. It's irregular, so it is AFib with rapid ventricular response. Okay, so that's cool to know. And what was going on? Well, he had an underlying both Parkinson's white, which is something we need to look for in patients with palpitations. Okay, post-cardioversion, we would go down and look really closely at these QRSs to see if there was any slurring, and there's no slurring. Okay, this actually, I'm sorry, this is the patient that had the thyroid disease. There was another one just like it that had the delta wave, but there's no delta wave. But his TSH was very, very, very off. Hi, buddy. Hi. Do you want to say hi to everybody? You EKG reading German Shepherd? So he had actually thyroid storm, and that's why he was going fast. So you always do a TSH. Always, always, always. Here's another patient who's 26 who has a syncopal. Yeah, syncopal episode. Okay, this is one of the big bad wolves we need to look for. The one I already gave you one of them, hokum, and now I'm giving you this one. Okay, this is Michelle's favorite thing. Michelle, do you want to tell everybody what this is? Do you want to come off mute so you can tell them? Jess and Teresa and Matt already got it, but do you want to tell them your explanation, Michelle?
Oh yeah, that is one of my favorites. It's Brugadas, and I have trouble remembering sometimes the words that go with different things if it doesn't make visual sense to me. So I always think it's brr cold in the V's, and nothing ever happens good in the V's. If something's going to happen, it's in your V way, in your V leads.
It's true.
So if you look in your V leads, especially V1 and V2, it looks like I could just ski down those slopes. And that's how I remember gatas, is to remember to look at those ski slopes in the V's.
Yeah. All right. And this can look similar to a right bundle. It's just a little bit wider than a right bundle. And there's no reciprocal changes, but the machine will read this as a STEMI. This is why I'm telling you guys, you can't rely on the machine. And it's ski slope, ST elevation, like Michelle said. And so Tori said it's her favorite saying, Michelle's saying. Now, just to let you know, Tori is actually somebody that's not medical. She comes along as our concierge every workshop and she helps people. She has no medical background, but she actually knows, because of repetition and the cool sayings that Michelle has, she knows this, which is like so cool. Okay. And this is how you take a mental snapshot and you're like, ooh, okay, that one, that's bad. Brugada, that's something that's life-threatening. That leads to sudden cardiac arrest in young people. And I need to know that finding. The machine's never going to say Brugada. It's never going to say Hokum. So if Tori can do it and she's not medical, think of what you can do if you're medical, right? The possibilities are endless for you. Remy, come here. Come here, Bobo. When I get really excited, Remy, like he's totally, he gets excited with me, huh, Bobo? Okay. So this one is a real amazing EKG. And why I say that is because we can practice. Okay. We can practice finding our lines. Okay. I love this EKG so much. So if you look at this, you can see, oh my gosh, like these lines, they start bringing out the ST elevation and depression. You can see here in 3 and F, you've got contiguous leads with elevation, and in lead 1 and AVL, there's depression. So what do you guys think? Does this meet criteria for STEMI? STEMI with Remy, what do you think, Bub? STEMI with Remy? Is it a STEMI? What do you think, Bud? Tell the students, is it a STEMI? So it is a STEMI, exactly. And this is how you do it. You look for ST elevation and depression. Okay. And we'll talk more about the CKG in class about what the rhythm is and all this other stuff, what happened to him, but it's just fun. This is proof that if you have artifact, it will mess up the QT 713. Good job, Logan. 713. This is not really 713. We covered this on night 1, but I just wanted to make sure you didn't forget. Always get a clean EKG. And the other take-home points I wanted to make sure you took home is that the president, the SA node, will always run the heart. Don't trust the EKG interpretation, trust yourself. Make sure you do the PQRST, making sure the family all goes together, and memorize your intervals because they will save you and your patients, which is ultimately at the end of the day, what we want. Now, I want to thank you for being here during this 3 days. I want to take my hat off if I had one to you. And I want to say, I know, Logan, you were asking for a hashtag. We do have a hashtag today. To give away a couple more of those MI windows. I think they're already all mailed off to the ones I had here to the people that won last night. So yes, the hashtag is hashtag 30day. Hashtag 30day. Now, I want to tell you, you're most welcome, KJ, and everybody who's here. The little RCAT window is the prize. We'll be giving away a couple of those to people who put the hashtag in. Thank you, Nuria, for being here. But if you want to stick around, I'm going to tell you a little bit about the schedule and how to join us in our 30 days so you can keep the learning going. Now, I just want to let you in on like a little bird's eye view of how we put this together. One day I sat in my living room and I was like, well, what can I make that's fun for people where they want to learn and they can get a little bit of solid footing with a mini class, which is what the 3-day is, and then springboard that and learn the rest really easily in the 30-day. Like it was designed to give you confidence and you could see that what's possible. And then we set up this whole program with all these wonderful coaches, including Michelle. Okay, so what's basically left? There's a lot of things left to learn, right? We're going to talk about cardiac farm. We're going to talk about all the really sneaky findings on the EKG. We're going to practice basics with the heart on a stick, with the EKGs, and KJ knows. Lynn is putting the hashtag awesome. We're talking about guideline updates, including HFpEF. We talk about CHF guideline updates, the new STEMI equivalence, that update. and we go through practice with you on it. We talk about new testing that's out. We talk about diagnosis. I share with you secrets about even the Apple Watch and how to make sure it sets up for the patient to win. Like we don't leave any stone unturned in this group. We don't just do EKGs. We do lots of things. So the schedule is set up to, so we had this today. So if you joined by last night, you got to go to this little bonus session with David, but we officially kick off this next week. Okay. So we're going to do a welcome call and kind of show you around the group on the 12th. We're going to do some basic rhythms, but the day before that, Michelle, are you still doing on the 11th? You're still going to do basics? I think you're going to do basics on the September 11th still?
Yes, I do
Okay.
basics on the 11th and practice on the 18th. Yes.
Okay. So, yeah, you can see this on the 11th and 18th. They're both Mondays. And so you'll learn the basics and then practice with Michelle, and everything is super visual. She even wears leads on her to show you where the leads are. It's totally cute. And then David has another study hall. Thank you, Tori, for putting the link. So there's a study hall with David where you guys tell him what you want to learn or submit EKGs, and he breaks them down. Like today, he did one for somebody who sent, and he went off on it for like a whole 10 minutes. He broke it down. So you can send in EKGs and he dissects them for you. It's super fun. So once every 2 weeks, David comes on. He'll hear what the group wants, and he'll put together a lecture on it. So then this is the workshop. So when we send you this box with all the goodies in it, this is when we use them on the 23rd. So you can see if you order this weekend, it has plenty of time to get to you. So you have all the goodies by the 23rd, which is when we use them. Everything on here is recorded. We do a lipid with our lipid queen, Whitney, on the 24th, where she talks about lipid cases. And then we do more EKG practice on the 30th. Now we go into October, of course. We have Gary coming back to do 12 leads. And then we'll kick off with our next 30-day, which will start over again and have more different lectures here. Michelle does a drawing session with coronary arteries. I'm going to do cardiac cases and then common chief complaints, how to work them up. And just know that if you missed anything here, if you were like, oh, I'm busy that week or whatever, you could just make it up here when we repeat some of these segments. We don't repeat all of them, but they're all recorded except for Gary's, like as usual. But it's really super fun. So we do lots of, hands-on time. We cover the dangerous things. We get you super solid and comfortable with them. And then we've been doing this for 3 years now. So there's a library of 3 years you get access to. So basically there's LVADs, there's stress testing, there's echo, there's STEMI deep dive, there's advanced EKG, there's basic EKG, like you name it, it's probably in there. We've probably done it. And it's just tons and tons of topics. So we show you on the welcome call where to find all of these. Are all stored there. It's really fun and easy. And you get 6 months access when you sign up, plus 12 hours of CE if you want it. So that's the fun thing. You get this kit, which has all these fun tools, including the workbook and the crayons. You get a customized painting that I mentioned earlier will probably be worth something someday, because I just got drafted to be in the San Francisco art thing, which I think I told you guys about already, but basically these paintings are going to be worth something. You're able to sell them one day, but they're cool to put on your desk and they're really cute. And then we have, all sorts of live coaching, and then we have self-paced, right? So you could do any kind of adventure you want to do. So here's the pricing if you want to join us for 6 months in this group. So student rate with no CE is only $149. So yes, do you get all the goodies and all the access? The same if you don't want CE as if you want CE. If you're EMS, 12 hours of category 1 CE. If you're RN, 12 hours, and NPPA, $299 for the CE of 12 hours, which is a lot. So we really want to see you inside the course. You get all these good things, right? At least weekly lives, which is a lot. We have guest speakers that come in. We have some other stuff lining up for you on this, by the way. We have the hands-on, we have the welcome kit, the 12 hours of CE, and I want to show you guys the box really quick so you know what you're getting. Now, somebody won one of these boxes on night 1, so you already saw this if you're on night 1. But basically in this box is a little painting. So this painting, this is actually one of my favorites right now. They're all different. This one has love, okay? So this one's like dark purple, dramatic, with a little stand. So this will go out to one of you that buys in the next day or two. That'll probably go out to you. And this is the other tool you get. You get the Arcat window. And this has all the cool stuff you can keep in your pocket. This is the big version of the badge. You get the crayons that we use in our workshop. You get these 17 EKGs, which are going to come, and they're not perfect. Okay. They're not beautiful like the ones in the books. So you actually get real EKGs. We diagram things, we color them. That's coming your way. We practice with that. We give you instructions on how to use your window tool that you got. We have a cheat sheet in here with the axis thing. I'm not going to show you that. That's my secret. And then we have this EKG that comes in your box that we actually carve up with the crayons, and we make that into a cheat sheet for you. And this comes as part of your package, whether you join as a student or whether you join at whatever rate. Now, I have a special bonus tonight. For the first 5 people that order, you're going to get this bonus. So if you want to do it, you should do it now. This is the cool little workbook, a binder that'll store all your notes. Okay, so on the back and the front, there's a cover. We got you some tabs that you can actually, you know, take the little tabby things and fill in and mark them. Like you could put this one, basic rhythms, this one, basic 12 lead. You could make this one the workshop. And Michelle gives us handouts too, you could put in here. And then I also gave you a little bonus workbook that you could also do in this little binder. So you're going to get the binder if you're the first 5 and the kit. If you're wondering before you order if you're going to be the first 5, just message me. I'll tell you really quick if you're going to be one of the first 5. But it's a really good bonus. So any questions, comments, or anything else, we put the link for you guys. And we'd love to have you as part of our family. Thank you for being here. But tell me if you guys have questions. I know that Michelle is has mentioned it. And yes, KJ says heart on a steak. Exactly. So cool. I think there's no other questions. Let me look back in the feed. Okay, so I will be announcing the winners of the badges too. The people who put hashtag 30day, I will announce that in Facebook because we won't be opening the Zoom again. And thanks for your time. Everyone have a good night. We really appreciate you being here. I hope that you walk away with some serious confidence. That's my hope for you. I want to make you more confident though. So I hope to see you guys all on the 30-day. Michelle, thank you for your time. Thank you, Tori. Thank you, everybody who is here, who participated and played with us. We always have so much fun with you guys, and we'll hopefully see you next week. Bye, guys.